Revision rhinoplasty offers a unique set of challenges. Cicatricial tissue. Altered or compromised vascularity. Distorted anatomy. The septal cartilage may have already been harvested. The need for reoperation usually includes displaced anatomic structures, undercorrection from an overconservative primary procedure, overresection/overcorrection from overzealous surgery, further tip refinement or correction of tip asymmetries. Approach. It is fair to state that revision rhinoplasty can be a rather daunting and difficult operation. This is especially true when revising someone else's primary rhinoplasty. Clearly, it is every surgeon's desire to prevent a revision surgery. The old adage that one has the greatest chance of surgical success the first time around is clearly accurate. Furthermore, no one will argue that any secondary operation is typically more challenging than the primary event. Not only has the surgical field not been violated, but dissection during a primary operation is significantly easier than dissection during a secondary operation. A major nasal complex deviation in the early postoperative period will not go away and correct itself, and once recognized, the surgeon must begin to plan for the inevitable revision surgery. Perhaps the most important consideration in revision rhinoplasty is determining what the patient's concerns are and then verifying the validity of the complaint with a complete internal and external examination of the nose. Understanding why a patient has chosen to leave the original surgeon and seek a new surgeon is also important. Once the patient's complaints have been determined, all previous surgical records must be reviewed, if original surgery was performed by another surgeon. A full examination of the nose is then performed. Generally speaking, patients with thick, sebaceous skin are much more challenging to revise. Presence of abnormalities such as bossy, convexities, or concavities along the dorsal side walls, degree of projection and rotation of the nose, and dorsal profile must be addressed. One must know how the nose was approached, endonasal versus an open technique. Another important consideration is the status of the septum. Is it still there? Most revision rhinoplasty procedures require grafting, therefore, if the nasal septum is still present, then it can be used. Asterisk note: one can determine the presence of the septum by gently pressing a cotton tip applicator along the quadrangular septum to verify the presence of cartilage. Postoperative synechia can certainly cause airflow restriction as well. They are thankfully easily addressed by simple cautery or excision. Gunter rhinoplasty diagrams are extremely valuable in the treatment planning phase. Some surgeons will routinely perform a nasoendoscopy or obtain a computed tomography in all patients requiring a revision rhinoplasty. Gunter diagram system showing color coding. Green, autologous grafts. Black, sutures and outline of anatomic structures. Red, incisions and excisions. Orange, previous incisions or excisions. Blue, implants. Timing. There truly is no consensus as to the perfect timing for a revision rhinoplasty. There are many factors involved. The old adage that you must wait an entire year to perform a revision rhinoplasty is without scientific merit. There is no physiologic explanation that somehow a twisted nose at 4 months after primary surgery will magically untwist itself by 12 months. If it looks bad at 4 months, it will look ugly at 12. A slight supratip fullness may respond well to massaging or steroid injections. A transcolumellar incision that appears somewhat red may respond favorably to wound care. Major postoperative issues such as new airflow obstruction, persistent dorsal hump, deviated nasal complex, widened dome, and lack of nasal tip support warrant a revision surgery within a few months, sooner than later. Conclusion. Accurate preoperative systematic nasal analysis and evaluation of the nasal airway, along with identification of both patients' expectations and surgeons' goals, form the foundation for success. Intraoperative key elements of success include adequate anatomical exposure of the nasal deformity, preservation and restoration of the normal anatomy, correction of deformities using techniques that provide consistent results, and maintenance and restoration of the nasal airway. The type of incision used is far less important than the correction of the underlying problem. Choose appropriately according to the deformity and your own experience. Always perform the dorsal reduction before harvesting septal cartilage so that the 10 mm L-strut is maintained. Preserve Webster's triangle when performing osteotomies. During postoperative recovery, care and reassurance combined with an ability to recognize and manage complications leads to successful outcomes following rhinoplasty. Telefaxes. Mustafa Ozgan, June 2017, said that the cause of bleeding in surgery is the surgeon, not the anesthetist. The best parameter that shows both pulse and blood pressure instantly is the end-tidal CO2 pressure, EtCO2. When injecting the local solution, make sure that EtCO2 remains between 30 and 34 mm of mercury. If EtCO2 rises, take a break from injecting until the pressure drops. Primary rhinoplasty refers to an operation in a previously unoperated nose. The term secondary rhinoplasty should be reserved for patients who had at least one prior rhinoplasty by another surgeon. The term revision rhinoplasty describes a secondary operation performed by the same surgeon who performed the previous operation. Preserving the patangui ligament is the easiest way to create the supratip break point. Generally, no more than 1/3 to 1/2 of the cephalic margin of the lower lateral cartilage should be resected with this approach in order to maintain nasal tip and alar integrity. It is generally recommended that at least 8 mm of cephalic strip remains after resection. One needs to be mindful of the domal region as the incision approaches medially to avoid over-resecting and destabilizing the tip. In surgery with a proper dissection, ecchymosis of the skin is not common. If it occurs, you may have damaged the periosteum or even the SMAS, or you may have compromised a vessel during local anesthetic injection. If the SMAS and subcutaneous fat tissue are damaged, nasal skin will look shiny for months. This may be due to the inflammation related to soft tissue injury. According to M. Eugene Tardy, with the possible exception of the nasolabial angle, no abrupt sharp angles, edges, or offsets exist in the ideal nose. In general, the most proportionate and symmetrical noses function the best. What should the patients be told in advance? All patients are told that noticeable swelling will last at least 2 months after surgery. The results of their surgery cannot be fully appreciated for at least a year after surgery. Individuals with thick skin are informed that the swelling of their nose will commonly persist for 2 years or more. The risk of significant asymmetry or undesirable features necessitating some form of revision varies in the 10% to 17% range and will depend on their particular anatomy, their course in the operating room, and the postoperative course. They also should be informed about the dressings they will have, the type and presence of any splints, the duration of these splints and dressings, and the time period for follow-up visits. In rhinoplasty, certainty is one of the enemies of professional growth. Certainty ultimately blinds you, sets fixed limits and creates automatic habits. The surgeon guided by his certainties is closed off to learning and far removed from innovation and progress in the discipline. There is no standard rhinoplasty operation because the underlying anatomy of each patient is unique. No single incision, approach, or manipulation of the tissues can be used in every case. For some surgeons, their biggest error is not the occurrence of the complication but rather mismanaging it or trying to ignore it. Frequently asked questions. Question: what is the typical age of a rhinoplasty patient? Answer: On the younger side, 14 is the earliest point. At that age the nasal septum and the nose are generally fully developed. For a safe and successful surgery, it's essential that nasal bones and cartilage are fully developed, typically by age 16 for girls and 18 for boys. Question: when should I see the final results of rhinoplasty? Answer: another of the common myths about nose jobs is that as soon as the swelling goes down, you'll see your brand new nose. It actually takes about 1 year for the final results to be apparent, since the cartilage, skin, and muscles evolve over this healing period. Question: will the scar be visible? Answer: the scar is located under the nose and is generally very small. With proper care, it fades significantly and becomes barely noticeable. Question: when can I blow my nose? Answer: you should not blow your nose for at least 1 week after surgery in order to promote healing and limit trauma to nasal structures. Question: can open rhinoplasty fix breathing problems? Answer: yes. Open rhinoplasty is often used in combination with functional procedures like septoplasty to improve airflow and correct structural blockages. Question: how long before I can return to work? Answer: most people can return to desk-based work within 10 to 14 days, depending on how quickly bruising and swelling resolve. Question: when may I resume sports? Answer: contact sports may not be permitted for several weeks/months. Any sports that involve the risk of injury, trauma, or strenuous activity should not be resumed until cleared by the surgeon. Question: if I wear glasses, when can I use them after surgery? Answer: it is better to use contact lenses while you have the splint on. If not, there is no problem to rest your glasses on top of the splint on your nose. Once the splint is off, you can use reading glasses or sunglasses straight away. But since there is a little bit of swelling in the skin at this early stage, it is preferable to wait for the swelling to settle. This may take 6 weeks or so. Question: when can I fly on a commercial flight after surgery? Answer: it is preferable to wait 48 to 72 hours before traveling in a plane after rhinoplasty. Most patients are advised to wait for 10 days before going overseas. Question: how soon after rhinoplasty can a patient get revision surgery? Answer: generally, patients who are disappointed with the results of rhinoplasty surgery should wait until the nose is completely healed. It is also good to keep in mind that final results of rhinoplasty surgery may not be apparent for up to a year after the procedure. Question: is it possible that my nose is getting bigger with age? Answer: actually, it's fairly common for the nose to change shape with age. Cartilage can become less supportive, causing the nasal tip to droop, making the nose appear longer or resulting in a hooked tip shape. Nasal skin can also thicken, causing the nose to appear larger or wider. The successful rhinoplasty surgery is judged over a period of years rather than months, as an approximation of the rhinoplasty result is not seen for at least 1 year after surgery, and further changes in the nose occur over the course of the lifetime of the person. Bottom line: the most conservative option is often the best choice. Rhinoplasty is achieved through harmony between form and function. There are 2 natural planes of dissection. One is the plane between the subcutaneous fat and muscle/fascia, and the other is between the deep areolar tissue and the perichondrium/periosteum. Historically, conventional destructive and irreversible tip modification techniques such as cartilaginous resection, transection, morselization, and scoring have been replaced by non-destructive, reversible, incremental, and dynamic tip suturing techniques. The popularity of visible/palpable cartilage grafts placed in a subcutaneous pocket underneath nasal skin has declined in recent years in favor of invisible/non-palpable grafts placed within or underneath the cartilaginous framework. Care must be taken in septal surgery to remain deep to the mucoperichondrium layer, as inadvertent removal of perichondrium on both sides of the septum can lead to ischemic necrosis and potential cartilaginous perforation. Do not operate on your patients during their menstrual period. Bleeding and edema can be more significant during surgery, and you may lose your control over the surgery. Swelling and bruising can be more intensive. The same problem can be seen in patients who use oral contraceptives. The risk of infection in rhinoplasty is quite low but possible. Before saying goodbye, the surgeon reminds the patient to expect a phone call from him every 2 days to discuss the postoperative evolution together. Giving direct communication channels to our patients is part of the comprehensive rhinoplasty service offered. In all rhinoplasty, a clear understanding must be reached between surgeon and patient regarding the perceived nasal deformities, surgical plan, and expected outcomes.